Okay, thanks, Dr. E. Good to have you on board with us here. We have Dr. Evan William with us as well. I'm going to start off. I have Dr. Brian Weitz, but I'm going to start off by showing a couple of cool features that we have in PayDC. First thing I want to walk you through is what happens if you have a new patient call in. Well, right off of our home screen, you'll see that there's a button over here on the left of our home page to bring in a new patient, but there's several different ways to bring in new patients. You can also put a new patient right onto the appointment book to the side over here, click the time you want that patient to come in. And the same way that that works, this will open up and just show you the 5 mandatory fields that have to be filled out before that patient can actually make an appointment and come into the office. What I like about this particular screen is that if they give us an email address, we could send them a HIPAA secure patient portal that they're allowed to fill out their demographic information, their personal health information, the review of system information. If it was an auto accident, in this particular case with this patient, there would be a checkbox over here that he was in an auto accident, and we send them off an email immediately. We can also add more information, but this is the minimal information that you need in there. If the patient's at home or in their car or at a coffee shop and they want to fill this out, no problem, as long as they have internet connection on any kind of device. They can open this up. There's the hot link to get into the patient portal. They'll need their ID as well as a temporary password. The temporary password allows them to come in. They're told to now change the password to something that they will remember and that is specific just to them or their family, so they can bring that in. Once they've created that link, they fill out their patient demographics. Now, this is a little bit longer than what you see here, but it gives us all the information that we need about that patient, and that goes directly into the patient's record. If we want to know about the patient's review of systems, their past medical history, or other conditions that they're dealing with, this is their patient condition screen. And it gets into some detail, goes into review of systems on each particular system that we need to have. And again, that does not just go into the patient's data file, that will go into the patient's subjective note for their initial visit. And it can be pulled up again at any time. And it creates a very, very secure and compliant narrative for the patient's initial subjective.
Dr. Evan has a video on YouTube about the online scheduler, and a patient can, if you have a link on your website, it can go to the online scheduler. If they sign up as a new patient, it will take them straight to this without you having to register them at your office. Is that correct?
That's correct.
That's awesome.
Okay, so here we go. Fasten your seatbelts. We're going to go off to Evan's screen.
Now, I could sit here and interview the patient and type in all this stuff and fill in all these blanks and ask them all these questions and check all these boxes. But the patient did it from home in that portal, that kiosk that Brian showed you. So if I hit import from questionnaires, it brings in the stuff the patient filled out from home. It already has all this selected, the way the patient selected it. They had the chance to fill this out. And I can just summarize it by opening up this preview, and I can read over what the history looks like. And if it looks good to me, I can keep it this way. If it looks like something needs to change or I got that wrong or something, I can go back in here and add other details if I want to.
So these bundles of diagnosis codes are already set up with these care plan samples in PayDC.
They are. Again, when I train a new client, I always I strongly encourage them to make it suit their specific preferences. So they can start with what we got, but I feel that removes some of the clinical decision making, because these are just, we teach clients how to customize this list. Maybe they don't want bicipital tendonitis because they would never diagnose it, but they want some other shoulder diagnosis. So we show them how to improve this list and make it their own.
Sure. And it's much easier to edit a list that's created than to have to build it yourself. So that's what I was getting at.
To outline what you plan to do during each stage and why, and have it automatically shift as the patient progresses throughout their course of care to show progress and change. In the strengthening stage, in this example, I stopped doing 97140. It's not even there, but I'm doing 97110, and it's got different descriptions here. That I'm going to do these kinds of exercises, different body part. This is only once a week, and this one is to help with range of motion and some other things. So every specific procedure has their own goals, their own descriptions, their own frequency, And it's tedious to set that up anew on every patient. That's why we have these templates, right? My standard protocol for shoulders might include these 3 exercises, so I can save a template with those exercises already preloaded. And then if I change my mind with that patient, I can just tweak them as I go.
Okay, can I jump in there for a second?
Yes, please.
So I know with working with docs myself is that commonly they'll bill a code and they don't have a therapeutic benefit, and an insurance carrier will turn that down if you don't list that. So that's great that that's preloaded.
And then here's the narrative that is more the clinical information. It says, listen, this patient has these diagnoses. These are the complicating factors. Here's the rationale for the x-rays that I plan to provide, that I'm going to deliver in my office because I have an x-ray machine. And I've assigned 3 long-term goals to this case, and here they are. This is what I hope to accomplish by the end of care. And I'm going to be able to update these goals periodically throughout care to show that I'm focused on them as my outcome at the end. And then here's the summary of the details. It says there are 3 stages of care, and we named them acute, rehabilitative, and strengthening. The first stage of care is here with every service and all of its details. The second stage of care is here with its details. And you'll notice that here I describe 97140 in the first stage of care. And here I describe it again, but this is the second stage, and so it has a different goal, a different frequency, and it's all outlined here. And the daily notes that occur during the second stage of care are going to change to reflect this information instead of this. And then at the end of care, I don't even have 97140. Again, I have other services that I'm doing, and they'll be described this way during the final 4 weeks of care. Okay, and then there's a signature at the bottom for the clinician. I'm going to go ahead and make sure the services that the care plan automatically plugs in there are the ones that I do plan to deliver. And if not, I'll change it. But you can see here under the assessment, there's the diagnosis codes that were assigned to this case. They got pulled in from the care plan. If I change my mind about some of them, I can delete. I can click on the X to get rid of them, or I can click on this button to add different ones. But these are the ones I pulled in from my template. And then here's my long-term goals. And they're right here. And today is the first visit, but at later visits, I'm going to use these sliders to talk about these goals. And hopefully by the end of care, I'll be 90 to 100% on all of them. And at later visits, I'll use these sliders as well to talk about changes and progress from day to day. When I get to the plan section, this is where I assign the services. So I did an x-ray today. I delivered treatment. And I want it to pull in the treatments right from the care plan, not the prior visit, because there is no prior visit, but we have that option. And I want it to automatically pick my CMT code, my adjustment based on the objective findings. So if we go back here, up here to the objective, you can see I have an extra spinal region and I have 4 spinal regions. So it's going to automatically pick the right CMT codes for me. You see that the plan now shows a summary of those objective findings. It copied them down here. There's the codes we're going to bill. If I want to get into the details for them, it shows 98941 for me, and all the details for 98941 are pulled in from the care plan. The technique description, the goals and rationales for that specific service. And if I open up the body areas and change my mind about one of these, I say, well, you know what? We didn't actually adjust these 2 regions. We only did these. It's going to automatically change the code from 98941 to 98940. And maybe the 98943, I decide I don't want to do it. Even though I had problems with the shoulder, I don't want to adjust it, so I get rid of it. It wasn't in my care plan anyway. It was just automatically added because I had objective findings there. For each of these, 97014, 97035, all the details are already in here. Each of these have their own goals and rationales.
Yeah, question. So where does that tie into diagnosis code pointers when you're doing it, when insurance carriers are concerned about what you're doing to what area of the spine and billing and treating separate areas?
Excellent question. Each of them are defaulted pointed to every diagnosis. But if I want to say that the manual therapy is in a separate region than the chiropractic manipulation, I can jump in here and say, okay, let's get rid of these diagnoses that pertain to the spine. And I'll keep these 2 here because these pertain to the shoulder. And then I'll go up to the spinal code and I'll get rid of those 2 extra spinal ones that I was referring to there. So now it just keeps the others. So now these point to different diagnoses. And so the doctor needs to do it here at this point in the care. Once it's done here, though, it's done. For every visit that follows, as long as you do the same services, those diagnosis pointers are saved unless you override them or change them.
I wanted to jump in really quickly there. Is the software that I have previous experience with, the pointers had to be done on the billing person's end at the front desk. So we had to go through this whole way to transmit that information from me to the person, as well as the massage therapist, what they were targeting versus what I prescribed. So we have all of these workarounds to make this happen instead of the doc being able to do it here. Yeah. So that's really great.
See, as far as I'm concerned, diagnosis pointing is not a billing matter. It's a clinical decision. And so our software has the clinician make that decision, and it's going to automatically push this into the claim. In fact, our software, before the clinician signs a note, checks this to make sure that it has the information necessary for the claim. So when I try to sign it, it checks this and says, oops, we can see that you forgot time. You didn't document time. These two codes require that. So I go in and I put in the time for these two codes. And in fact, if you look at this, if you're familiar with the 8-minute rule, I can only bill one of these, and the software knows that too. When I try to sign it, it's still going to check it and say, yeah, when we try to validate this based on the 8-minute rule, you can only bill one of these. In fact, I try to sign again, and it also checks for modifiers, the most common ones. It checks for 5.9 and 2.5, and for Medicare patients, it'll look for the AT. So the software told me I forgot my 2.5, I forgot my 5.9. Now the 5.9, again, you think that's a billing issue, but it's not. It's the clinician who has to say, look, that modifier applies because I did this in a separate region for a separate purpose. And now that I've added that here on the first visit, it will save this service every time I do it throughout the care plan. It's going to have the 5.9, it's going to have these diagnosis pointers. The only thing I have to add at later visits is the time, because that can vary from visit to visit. In fact, as long as I'm following the care plan, most all of this is all done every visit. I just have to throw in time and move on. But that's pretty much the first visit note. I believe that can be done very easily, including the care plan and the history, in less than 5 minutes. And I'm going to go ahead and I want the care plan to be included in this note. So if I go to save this note, I could sign it here and it would let me now, but let me just show you what it looks like. So, because I don't feel like it's worth it to clutter up the notes with the care plan over and over again, but here's the care plan. It says for the first stage of care, we're going to do that. The second stage is here. Third stage is here. So this note's about 4 pages long. Subsequent notes are usually a page, page and a half in PayDC, because we don't need to add all that care plan stuff again. But at the end of the note, we have today's treatment. And here's the 5 things I did today, or 6 things I did today. And this is what's going to go on the claim form, right down to the number of units for the time-based codes. All that's automatically going to fill in on the claim. Each of these services will be billed there with the modifiers that I selected and all that stuff. And then it'll have a valid time and date stamp down here if I signed it, which I haven't. Okay, so that's the first visit note.
Yeah, I know. So I know you went, this took a little bit longer because I kept jumping in and asking questions, but if I want to do it sort of like in the flow of things. About functional assessments, you described in the objective that you pulled those objective options directly from the oswestry. Often in the Anthem Blue Cross Blue Shield guidelines for Virginia, they want to know the name of the test that you use. Do you use the functional assessments through the treatment? Does the patient complete it? Does it populate automatically into the notes? And are the scores there? Because they also want to see it quantified with percentages, 50 based on those functional assessments.
Yeah, let me throw that in here. So I'm going to add the oswestry with a score of 40 to begin with. And I can put a note here to say see attached for original or something. So we actually don't have the functionality where patients can fill that out themselves online. They can do it on paper. We can record the score, and then we can scan it in and drop it into the file cabinet here. And so I can just go here and hit scan and drop it in and put a copy of that oswestry here, the original, with their signature on it. And once that's in here, then I could also add it here like I just did to the objective, and I put it in the outcomes. And now I have that outcome included here. 40 is the score. And I said see attached. And then at the next exam, when I re-administer the oswestry, the notes will automatically discuss it and say, the score went from 40 to 30, which is a 25% improvement. The notes automatically build that text. So that's how we handle those. We do have the functional rating index, or the FRI, included in our patient portal, where patients can fill it out themselves, and we can import that one because we licensed that one.
Something else that I like is that you have those colored areas in objective, the purple, the green, the yellow, and how those populate into the plan portion. Because I also review notes for chiropractors, and they often think just because I identified a subluxation in objective, then I can just say I adjusted them in the plan, but you have to state again that you adjusted those segments, and they're asking for that to substantiate your 9894 blank code.
Exactly. The note has been formatted differently. Every change is bolded. So when I get audited, no one's going to say, your patient never progressed, nothing ever changed. I'll say, well, what about this? What about this? Everything that's bolded here is a clear, identifiable change.
I used to manually bold changes myself in my old software because of exactly that. Because when you get audited, you don't want the person reading it to have to fight it to find what you want them to find. So that's great.
Yep, that's my pet peeve as an auditor, is having to sit there and compare. We actually got this idea. Dave Klein was doing an audit, and they went through with a yellow highlighter on printed notes and highlighted changes, and they were supposed to pay back like 80 grand, and then he went through and highlighted everything, sent it back, and it went down to $800 or something crazy. It was this huge difference simply because the reviewer didn't bother even looking. They just said, oh, they're all the same. We said, no, they're not. Look, we'll highlight the changes. So you can see how this daily note's pretty straightforward. It gets right to the point. Here's that goal. You know, it progressed a little bit. Patient showing slight improvement. This particular service changed today because I did different segments. This one was exactly the same, so it's not bolded. And this one, the only thing that's different is the time. And it should be signed. I didn't sign it, but so that's how the subsequent notes go.
I see lots of good stuff. A couple questions. In your plan, it says, and it brought on the diagnosis codes, it says performed by. In an office that has massage therapists, for example, again, in the Virginia Blue Cross Blue Shield guidelines, it says it wants the notes signed by the provider who performed the services if it was a service that requires licensing by the state. So we had our massage therapists set up as providers. So we would prescribe the service in the doc's notes, and then the therapist would sign in and click their own thing so it could be electronically signed as well. That was a workaround again.
So we have two ways we can do that, and it varies depending on the states and their rules. But basically, Martha is my massage therapist in this office. She can be her own provider, do her own soap notes. That's one way to do it, and have her own. It would be her MPI, you know, assigned to it, whatever. If, on the other hand, you just want to do this is Dr. Hancock's notes, and let's say this was massage. I just put in here performed by Martha, and I can then set it up so that the doctor is a supervisor, and I can put both signatures at the bottom of this note. So it's the doctor's note. The note reads that Martha performed this particular service and pretend like it was massage. And I can put two signatures at the bottom. So down here right now, it says, you know, this was massage. It says performed by Martha Martin. And then we can put a signature that says supervising signature, and it can be the doctor, and then rendering provider signature. We can do that way, or have a completely separate note and pull this out of here and put it in the other provider's note, the massage therapist. So
Great.
two ways.
So is that something that PayDC would help the provider set up to, like, those extra steps?
Yeah.
So,
yeah. That'll all be done in the training when we set up the account and say, okay, this provider needs to be labeled as one who needs to have a counter signature. So providers in our system, by default, just sign their own notes, but you can also set up a provider that they require a supervisor signature. If you feel like you want to have dual signatures, that's a different option. Or you just set up the massage therapist as their own provider, and they do their own notes. And that's that. But I just, in Virginia, do you need to bill that massage therapy under the MPI of the chiropractor?
It's still the chiropractor, but if it's a service like massage that has to be performed by a licensed person, if it's not the chiropractor, they want the therapist to sign it. They want the license number and the expiration date of the license number in the signed portion of the note, which is a little above and beyond, but that's sort of how it is.
Yeah, we should be able to do that without any trouble. I mean, we got.
Okay. Going back to soap, a problem that I often find in notes is that there'll be a conflict between the patient input subjective and what the doctor says. For example, the patient will always say, I'm an 8 visit after visit, but yet the assessment will say the patient's getting better. And the doc doesn't go back to kind of review that. So depending on the software, I would recommend is that let the doctor put in the subjective. But that's when there were different tabs, and you'd have to make that extra step to go look at the patient's subjective if they put it in, but this is all on one screen. So I think you as the provider need to keep an eye on that to make sure they're congruent.
And the provider has the choice of whether or not they want the patients to update their own subjective. I just logged in as Amy, and this is what Amy would see if she logged in herself at the front desk, and she could go through and see this, and she might just skip over this and not even, change this. But if she changed it to a 5, and she went in and added these details or something, let's just pretend like this makes sense, and then hit save. So she has just updated her data, she finishes, and now the next patient can log in. If I go into my notes now, and I go to add a note for this patient, what you'll see is the provider can see what the patient changed and can override it if they want. Or some of our providers say, I don't trust patients, I'm never gonna let them do that themselves. See this, it says the patient checked in a few minutes ago, and when I click on this link, here's a summary of what the note said last time, here's what it says this time, and the provider can review this and talk to the patient about it, or say, you know what, Amy, I think you're a liar, I think this is an 8. So I can simply override what the patient put in.
Yeah.
I don't have to trust my patients to do their own thing, but I can let them do it, and if I want to, I don't have to change anything and just move on. So that's how we handle that comparison to make sure the provider sees what the patient did.
Okay. Only an observation again about the Blue Cross Blue Shield in Virginia. in the guidelines, it states that it considers re-exams along the care plan to be part of the care and not something that they should be paying for, but only to charge for a re-exam if there's a new condition or exacerbation. As an expert in billing and documentation, what do you recommend for that?
Well, first, I disagree with Blue Cross on that.
I agree too.
And second, if you wanted to record that you did an exam on a patient here, but not charge the third party for it, it's very simple. Let's say that it's time for the re-exam. Basically, you go in here and designate it as an exam, and then it imports the exam findings. So it brought in the prior exam, so I can do those. Like I told you before, I open it up, and it shows me, hey, last time they were here, these were positive, and maybe this is now negative, and this one I'm not going to re-perform because it was negative before. So that's my re-exam. I update those changes. But when you go down here to the plan section, if the care plan called for a re-exam, it would automatically import it. I can't do that yet because it's only visit 3. But if this was visit 6, I think is when I told it to, it would automatically bring in an E&M code. Okay. So here, now that the software shows that I did an exam, it's a 99212. If I want to bill it, I simply bill it. If I don't want to bill it, I check this box. And now the note says I did it, but it's not going to get billed. It's that simple.
That's great.
Because this is excluding it from the bill.
Sure. Which is just, I find most providers haven't read their guidelines. And so, and everything is in the
paid.
Yeah.
Well, and Blue Cross all over the country has been kicking back against re-exams. And, to me, it's like below the standard of care. Like, we need to re-examine our patients, and they say, yeah, go ahead, re-examine them. We're just not going to pay you. I'm like, no, it's extra work. You should get paid. Anyway, don't get me started. We already got you started, so we don't need both of us started.
Now, another question, since again, this is cloud-based, what about all of these security stuff that's happening and people's computers getting locked up?
So PayDC is cloud-based, but not browser-based. Some of our competitors have had breaches in the last few years, and they were open through a browser. PayDC, in fact, I'll close it here, is not a browser-based program. It's a Windows program. It launches straight from Windows. That allows us to leverage certain security advantages because it's a Windows program. So all the data is out on the cloud, and you have to install this launcher on a Windows device, but you don't go through a browser. So you can install this on as many machines as you want. We have unlimited workstations. We don't care about that, but you don't get in through a browser, which is a security risk. And then, of course, we use Microsoft Azure. That's our servers. We don't have a garage full of computers somewhere. Microsoft is the one who's hosting our cloud, which means we have the latest and greatest security. And if someone can break into Microsoft, yeah, they can hack into your PayDC. But Microsoft is going to have the resources to have the best and greatest security available. And so that's one of the reasons we use them.
But I do want to touch upon billing for a second to let everybody know that in billing, for electronic billing, for what's called electronic remittance advice, when you send out electronic claims and come back, they have to go through a clearinghouse. Your clearinghouse fee is part of your PayDC monthly subscription fee. There's no additional fee for clearinghouse fees. It's already built in, and we use the one we're using actually is Infinity, which is built into the system, and they work on every single insurance company there is in the country.
Okay, and that is really important if we end up using this recording, because Infinity keeps our data, and we can use that to fight back about against insurance carriers when they do shenanigans telling us about what our data says when it really doesn't say that. So I'm really thrilled that you're working with Infinity.
Yes, and they're a valuable partner to us.
Yes. And then what about if you're using an external billing service? How does that get set up?
This is great because this is cloud-based. There's 2 ways to do it. But the cleanest way is to just train whoever that biller is, whether they're internal or external, and just give them a login, and they can log in remotely from wherever they are because it's cloud-based. And then we train them. Our billing is very straightforward: claims, posting, reports. So this is the claims. If I want to submit them to Infinity, I check the box and I hit submit, and then you're done. The way the claims got here, we signed a note. So if the provider signs the note and finishes it and says, I delivered the service, then there's a claim ready to go. And all you got to do is come to the billing tab, choose the ones you want to submit, and you can do them every day. You can do them twice a day. You can do them once a week, whatever, and submit them, and they're done. And then they move through these buckets here as you track them, and you see, oh, there's my submitted claims. Let's see if I have some samples if I go back and You know, I have claims I prior submitted, I'm waiting to hear back on, and the ones that are done, ones that I've rebilled or put on hold. You'll notice under generated claims, some of these are gray, and when I check the box, it won't check the gray ones. That's because we're going to scrub it for you and check and see if something's missing. And if you hover over that, it says this one, item 10 is messed up. On this one, the address is missing on the patient. So I can click in here and see exactly what's wrong with the claim. Our software identifies that. And you look at the claim here, there's the claim and there's the red stuff that's missing. They have no address. So I can go back to the patient's demographics, update their address, and then update the claim, and then it will turn it from gray to white, and then I'll be able to submit it. Okay.
Let me add a couple pieces there. If you notice that it generates the claim form itself, you no longer have to purchase the claim forms and print on the claim forms and worry if your data is falling into the right boxes. This is all a one-stop shop on that claim form if you need to print out your claims, such as for personal injury claims. But Evan, we need to say, if the client wishes to use a third-party biller, why not use a biller who is so comfortable and knows the system like the back of their hand? We offer that service at a very competitive rate. If they're interested in, it is a sister company that's part of PayDC. It's called PayU, and we have a number of claims reps that work with us, and what will happen, they will scrub the claim. They will fill in whatever they can. If they need to contact the office, they contact the office. Once the claims have been scrubbed and they're clean, they go out immediately to the clearinghouse. If there's any pushback from the clearinghouse, we correct it from our billing department, not you, as well as once the claims do come in, if it needs to go off to a secondary, our claims reps work on the secondary billing. If there's denials or underpayments, they fight for that money as though it's their own. There's no extra fee for that. So when you're hiring an outsourced billing company, you really want somebody who knows this software like the back of their hand.
I know offices where they have an external billing company that signs on remotely to their office server and that extra step. So cloud-based eliminates that, which is awesome. And now one thing that you said, Evan, is that when the notes are signed, they go into billing. So an unsigned note does not go into ready to bill.
That's correct. You cannot get paid for an unsigned because you didn't pay the service.
Yes. So then there's a report that if there happens to be unsigned notes that slide through, that the doc then gets so that they know to take care of them. Is that correct?
Yeah, right here. Unsigned notes. I'll just generate it and see if there's any in there. It looks like I have one, the one we just did. So there's the report, and you just go back in and find the one that you missed. But you know, you notice though, you also can see that when you're actually in a note that's unsigned, it shows it in red.
I have talked to docs who were audited and they were hitting a save button, but it wasn't signed, and they ended up not getting paid because there wasn't that electronic signature.
But just know that it's not going to get billed until the doctor signs off on it. And, you know, timely signatures is an important compliance issue.
How about addendums? Or...
Yeah, sure. So if I go to this note that was already signed previously, you know, it was from July 6th, you notice now I can't sign it again. I can't edit any longer, right? So addenda is just like this, and I can say, also, we found something else like this, and I put in whatever I want, and I save and sign, and now at the bottom of this note, there is an addenda right there. So this is a note from here and above, and then it says addenda, here's the extra information, and this was added on July 9th.
I like it because normally with other programs where you can open it up, you do an addendum, you re-sign it, and it changes the date, and now you're out of compliance. So that's excellent.
Okay, I'm going to run you through some actual Chirotouch notes. I'm not sure what yours look like. If you do not have version 7.0 or later, they're probably pretty awful. Now, these notes have a lot of the elements you do need to have, but it's messy. This is Chirotouch, and one of the things now that I've been using PayDC for about 2 months is their narrative notes are neat, they're concise, they're attractive, they get the information across without being, I know you see, this may look familiar to you like your notes are not, Again, these have most of the elements you're supposed to. You do see some bolded area on that note. That I manually had to bold in order for that to look like that to stand out to a potential reviewer. Let's see, treatment plan. Now we're getting into the functional rating index, my functional deficits, my short-term goals, my long-term goals. But it's not really pretty, and it's hard to find the information that I've spent a lot of time trying to put into these notes. I'm also going to show you in a second that we needed to do an addendum to the note, and in Chirotouch, when you do an addendum, a week later, a month later, or 6 months later, it erases the date stamp. And so I had to manually put in when the original notes date were, and then, it's just a mess. So make sure you look at PayDC's narrative because they're beautiful.
How about somebody who has another program now and they've been fighting with it and they're not sure if they want to switch, and how, as far as implementing and transferring the data over to PayDC, how difficult is that? What kind of errors can people expect to have?
So here's our implementation process. And often with new clients, I say, listen, if you have a system in place, and you have all these patients under active care, and you have all this AR going on, I think that you should keep that going for 2 or 3 months. And it'll take us about 5 or 6 weeks to get you trained and ready to go live with PayDC. But I advise you to see your old patients until they finish out their care plans potentially and get their AR to a more reasonable spot in your old system before you, and gradually add new patients to PayDC as you go forward, because the transactions from your old system don't translate over. What we can import is patient names, address, phone numbers, but transactions are going to be separate. And you have to start transactions at some date in PayDC. And we usually say plan on 5 or 6 weeks before ready for that. But in the first few days, we get a trainer in touch with the client who lays out this plan with them and says, here's what we're going to do. We need to meet with you, once or twice a week. And in the middle of the training, I meet with the clients to do the documentation training. I do that myself. And Brian, since he's been with us, is there with me on those too. And then they go back to the trainer who finishes up the training on the rest of the system. And 5, 6 weeks, they're ready to go. This includes the clearinghouse, all the settings in the system and getting it all ready to go, customizing how they want the notes to look and all that fun stuff. We also offer 6 months access to a trainer for included, unlimited. So some people, they take longer to train, or they want to be trained again 3 months from now. Some of our competitors will charge extra for tech support. We don't. It's like we don't charge extra for the clearinghouse. Unlimited claims, it's all included.
And I just would ask anybody who's interested, please get in touch with PayDC. Just go to paydc.com. You can schedule your own personalized demo, or there's a number that you could call to contact one of the representatives. So thank you very much, Ellen, for having us on with you today.
Great, thank you.